Thank you very much for your introduction. Today, what I'm going to talk about is about the practice in rehabilitation in post-stroke patients. And the story that I want to tell is in majority of the training these days for post-stroke patients, as what you know, post-stroke patients, they have different functional deficits. So these different functional deficits might not be able to return at the end of the rehabilitation processes. So majority of the therapists, when they are working in hospitals, the way that they train the post-stroke patients are more, you look at me, I demonstrate to you, and then you follow what I did. So for these particular series of studies, we want to persuade the field that actually these type of instructional learning might not be very appropriate for post-stroke patients. You might not be familiar with post-stroke rehabilitation, but just recently in 2016, actually there's guideline published to guide the therapy and also rehabilitation for patients with post-stroke patients. So basically, as we can see here, I highlight here, is there are a lot of trainings that post-stroke patients might receive, but the most important actually is to train them to return back to their life. So basically, we are talking about training of daily activities in the hospital and also in rehabilitation center. And this is what I refer to. In most of the cases, the patients would learn instructionally. So what it means is I demonstrate and then you just follow suit. We have been proposing this self-regulatory learning for many years, and we now see more and more therapists and also settings adopt this kind of training. So basically what we put out is, at a time when we train the patients, we want them to just first of all think about the task that they are going to do, and then they might want to chunk the task into detailed subtasks. And then look at which task on which subtask that they cannot do. And afterwards, in week 2, we just demonstrated them how to do how to solve problems and identify the problems that they have at the subtask level, and think of ways to solve the problem, such as instead of walking, they may want to use a wheelchair, or maybe instead of use a wheelchair, they might want to just sit on a chair. And afterwards, week 3, week 2, we then ask them to just imagine, to just rehearse what they do, what they would want to do before they act they put on the actions. So basically, it's a 3-week program that we put out. Those are the tasks that I refer to. You might think that this is very trivial, but actually when patients go back to home, this is what they need to do every day. So if they got stuck, they wouldn't be able to get independent. Now, there are 2 theories or 2 processes that we think is very important in terms of this self-regulatory learning. The first is mental rehearsal and also mental imagery. Earlier on, one speaker talked about actually this function is pretty much preserved, even though when the patient suffered from very severe brain damage. So we conduct study, and then what we want to look at is we want to disentangle the processes associated with mental imagery. And this is the study that we conduct, which we use sound instead of other images. And then what we found was actually we did not use brain imaging, but more use event-related potential. So what we found was actually there were 2 major events or processes that occurred. The first is denoted by the P200. This is a positive wave occurred at around 200 milliseconds, and that more relates to the attention allocation. And then this is followed by another event, which is a late positive complex, which mainly looking at or indicating the access to working memory and then pull images in the working memory. And a more recent review paper, not done by us but by others, this demonstrated that in mental rehearsal or mental imagery that involved generation of image, that one needs to go to the long-term memory, and then these images are maintained and also reviewed and also inspected in the working memory. So this basically is the processes that we relied on when we asked our patients to conduct mental rehearsal before they take the actions. The second theory also we very much rely on is the prior experience modulating learning. And actually this is a pretty new concept in rehabilitation. Because in rehabilitation, most likely that you will look at what the patients cannot do, but instead of looking at what the patients can do. But we conduct studies in blind people and showing that actually the prior experience is very important, and then it also involves a very different network when we compare with those without prior experience. And this concur very much with what the previous speaker talked about, congenital blind and also the late blind. So for this series of studies, actually we used people with blindness, and then we use auditory signals. And this is the device that we designed, which is mainly to help blind people to navigate. So instead of we use semantic messages, these Badger device mainly is to emit ultrasound. When ultrasound hit the surrounding, hits the obstacles, then there's echo going back to that device, and that device will just down-regulating these echo signal to just sound signals. And this sound signal would be very crude, which is just like beep, 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 or beep, 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 that indicate near or far, or even indicating directions. So basically we put individuals in the scanner, and then we give out these sound signals. So this is the design, and then our sound signal both carries a distance and also directions. So individual would need to differentiate the sound, where the sound came from. Would it be the right, the left, the middle distance, or far distance? Now, in our first study, we only involved congenital blind, and then also with individuals with normal vision. And then what we found was there are three regions of interest that we identified. I want to point to you the second ROI, which is the left hippocampus. What we found was for congenital blind, when they learn this sound, how they're different from normal individual is actually they use a lot of their left hippocampus. So what's the function of hippocampus? Left hippocampus mainly is to do binding. So basically what it means is, in terms of learning sounds with the visual spatial content, the congenital blind, they mainly relied on memory. In particular role memory, whereas this was not the case for normal vision subjects. In the next study, what we did was we recruit other groups of congenital blind, but then we compared that with the late blind. And then what we found was, actually this is, we used the PPI to do the analysis. What we found was within these two groups, among the late blind individual, actually precuneus is the main neurosubstrate, and the precuneus actually connected very strongly with the lingual gyrus network. And then we further correlate the activation of the lingual gyrus network. I do not show this in this slide. Actually, it highly correlated with the visual spatial working memory. When compared with the early blind, precuneus also is the very major neurosubstrate, but we found that the precuneus connected very strongly with the limbic multisensory connectivity. And then when we look at it, actually it has also the hippocampus. So basically what we found here is, with prior experience, when individual learn, they actually recruit the network that previously involved in the learning. Whereas if with those without prior learning, then most probably they would it would involve only the hippocampus. That means is rote memory. Now, in terms of the self-regulatory learning that I just talked about, Actually, we published in the paper about 10 years ago, and then we published it in a journal. And then what indicate is by having this self-regulatory learning, the most important actually is not the just do better, just perform better on the task that we train, but also we found that they also perform much better than the control group in the untrained tasks. So basically what it means is they were able to use a strategy which identified the problem and then solve the problem before they did the action. Now this was the design that we did. We basically used tasks. We trained, for instance, 10 tasks or 15 tasks, and then we also did not train 5 tasks, and then we tested both the trained tasks and the untrained tasks. And for the trained tasks, we also test them with unfamiliar environment, and then we found that also the performance were also higher or better. And this is the learning processes. So I just run through it again. We asked them to perform a task, but before that, we reminded them that to think about the task that they did, and also the task that they would do, and then they identify the problems. And then they think about solutions and mental imagery rehearsals before they did action. And then we actually conduct about 4 randomized control trials, and then we found very consistent findings across these different trials. And we actually still conducting the data analysis, but I just want to share with you our preliminary finding. We conduct a functional brain imaging studies, and then we actually trained patients, and then using these clinical procedures, and then we put them in the scanner. And in the scanner, what we asked them to do is, first of all, we show them a clip of the task, and the task is only a subtask. And then we ask them to think about these subtasks, and after that, we want them to just think through their processes, and then after that, then they would need to tell us whether they would be able to do this task or not. So basically, they went through this mental rehearsal, they went through these analysis, evaluation, and then gave us a response. And then what we proposed was, once when we showed them the task, they would do goal setting, recognize the tasks and subtasks, and after that, in the 3 seconds to 4 seconds, then they did this mental rehearsal, and then we proposed that it would have this goal-driven planning, visualization, appraisal, and decision-making processes. And then altogether, we recruit 3 groups. We have the training, we have the post-stroke patient self-regulatory learning. We have the post-stroke only instructional training, and then we also have a healthy group, which we conduct the self-regulatory learning. So we have 3 groups, and then we train them for 10 days, and then these are all the tasks that we involved, and then these are the design, the number of trials. So preliminary results. The first, we asked the question, what processes are associated with self-regulatory learning among healthy adults? So we just contrast the activations, untrained tasks versus the trained task. So what we found was the 2 main neurosubstrates, one is fusiform gyrus, the other is MOG. And this basically means is actually the individual thought about the actions, and then also involved the body schema, and also heavily having these visual processing. So this is the healthy group, underwent self-regulatory training. The next question is, what processes are associated with instructional learning among post-stroke patients? Those are the patients in the control group. We just I demonstrate and then you follow. If you do not find you can do it, I'll do it again, and then you follow me and do it again. And then we also contrast the untrained versus the trained task. So basically, we just thought that if our previous finding in the blind individuals worked, that means is these individuals most probably will need to go back to their memory and then to search for solutions and then search for whether they previously learned it or not. So the 2 main neurosubstrates are, one is dorsolateral prefrontal cortex, the other one is precuneus, and then these 2, one is control, the other one is judgment with reference to autobiographical memory. So these sort of support our hypothesis. The third question is what processes associated with post-stroke self-regulatory learning between post-stroke patients and healthy individuals. We just want to know whether the processes are different. And the main processes that we think different is because the stroke patients, they had problems. There are tasks that they cannot do, whereas for healthy, they can do. So as what you can see here, the two major neurosubstrates, superior temporal gyrus and the anterior cingulate gyrus and anterior insula. Now, this is the most important question we ask, is what processes are associated with self-regulatory learning among post-stroke patients. So we compare stroke, the experimental group with the control group, and then untrained task with the trained task. What we found was there are three neurosubstrates of the frontal gyrus, anterior temporal loop, and also anterior insula. To further look at which neurosubstrates are more important, then we conduct ROI. And what we found was of the frontal gyrus, actually there's no involvement in the untrained task processes. So basically these neurosubstrates actually might not be involved in the question we asked. Then we look at anterior insula and also anterior temporal loop. You could look at the blue lines that actually show differences between the control group and the experimental group, particular untrained tasks. So the functionality mediated by these two neurosubstrates, what is the coding of actions and also evaluation of the outcomes of the intentional actions. So basically what we think was these two processes are the most important in self-regulatory learning. To conclude, the theoretical underpinning of self-regulatory learning is bottom-up perceptual process. That means is once when the patient receive the task that they need to do, these are the processes that are involved, and a top-down control, goals directed review, appraisal, and decision making. We also know that mental imagery and execution are very much involved, and also these enhance success in performance, possibly benefit self-regulatory efficacy, and also promote participation. So to conclude, we want to show the field that these the self-regulatory learning may be more appropriate for post-stroke patients that work against the demonstration and practice instructional learning that are very common implemented in rehabilitation of post-stroke patients. So I want to thank you. These are my collaborators. Thank you very much for your attention. Thanks.
Now